Today, thank you, Sophia. So thank you everybody for coming. We're so glad you're here for our first event at UCI. Um, Today we're welcoming Dr. Keshishian. So with that, take it away, Dr. Keshishian. Thank you so much for being here.
Um, Thank you, everyone. Thank you, Sophia and Miranda, for inviting me. And if at all possible, and I know some people may not want to do this, if you guys can open your cameras for the first, let's say, 5 or 6 slides, then you can turn it off and go to sleep, and I will know. But there's some interactive part of this that would be, um, I'd like for all of us to see each other's reaction type of a thing. Um, so with that, when Sophia was asked me and through Miranda, to give a talk, it was like, what do I want to give a talk about? I thought I can sort of throw a whole bunch of things into this, what may be a rather disorganized talk. The idea is that to sort of um, show that everyone is going through this preparation work either in pre-med or medical school. We've all been through this one way or the other, and the title of it is Chart Your Course. And can you make this work now? What I've said, those of you that have had the pleasure or the displeasure of having to deal with me more than this half an hour of talk, you've heard me say this repetitively that you got to keep your eye on the ball. The path to where you want to be is never a straight line. There's going to be a lot of ups and downs and left and right turn and unexpected things that school life, getting older, being a responsible person is going to throw at you, and you just have to deal with it. Keep your eye on the ball, and you have to be all flexible with this. Um, Here's sort of the boring disclaimer stuff. What I'm going to share here with you is my experience of uh, going from Glenda College to engineering school to medical school residency, and here I am 30 years later, nearly a few blocks from Glenda College where everything started. So this is an example. I'm not here to give educational advice, even though I may have my own strong opinions. Um, as I've stated, I think it's very important to sort of set your goal, and it's very important nowadays, and that the you set your goal with the realistic expectation. And I'm putting that as like a third item because I think it's very important to appreciate that the expectation that you may have, uh, or well, the expectation that I had when I got into residency may have been one thing, and the reality of what I ended up being in private practice as a general surgeon sort of changed relatively quickly. So if you're thinking about what is why am I getting into medicine, for example, what do I want? The reality of that has changed. Educational variables are changing, the job security issues are changing, and so forth. One of the, I think, biggest surprise to a lot of people that have, especially come after maybe 5 or 10 years after I graduated from my surgical residencies, is that you would think that after finishing residency, there's someone rolling the red carpet, and you show up in the office and you see patients, and they just sort of pay you your salary or you get reimbursed, and everyone, yes, doctor, yes, doctor. That sort of happens maybe in Hollywood, but it's not in real world. As a joke, I'll say when after my residency, I was hired into this small group of general surgeons in the middle of nowhere in Central California. And I showed up, so after we signed everything, and, I took a couple of weeks off to move from Detroit to California. And so Monday morning is my first day. So I put my best suit and tie. I wear bow tie and white coat and walk to the office with my briefcase. I go to my office that there were three of us in the office, and I sit there, and Dr. Anderson comes and says, what are you doing here? I go, well, it's my first time here to see patients. You don't have any patients, you don't have any providers, you are not any contracted, we're still working on privileges, go home when we need something, we'll call you back, or you can just hang here and sort of loiter more or less. So it sort of, it was like my first reality shock that, what do I need to do as a surgeon to get there? So there's it's a variable that you have to really appreciate that. Um, Perspective versus reality, what I see versus the reality. I think as physicians, it's very important we appreciate a couple of things is what we really see is not we need to distinguish whether what we're looking and what we're seeing is real or not. So we're all a product of our life experiences, our family dynamics, our educational experiences, and our training in our post, medical school. Where you trained, what kind of cases or patient population you see will uh, mold your uh, future as a physician. And it's very important to sort of consider that in the backdrop of where we're all coming from. Um, again, going back to, some of you that I've known much closer when we've seen patients to each other with each other in the office, you'll appreciate how many times uh, my job as a physician is to try to demystify or compete with Dr. Google and Dr. Facebook and people that get their news information from other sort of questionable sources. And I also love this thing, the infamous assumen. When you tell them, well, this is what I think you should do, but in the assumen sense, or well, you never know who is assumen type of a thing. So this is where I want to go. If you guys have your videos up, I want to sort of show you something, and I'm just gonna sort of. This is not a trick question. So this is about a minute of 1.5 minutes of video. We can all watch this together, and so I'll just open this up. Did anyone notice anything else? Feel free to say or share what you saw. Anyone? Who saw
Um,
the gorilla?
yes, I saw the gorilla.
All right. And what else did you guys notice? Any color changes? I guess I should play it. Did you also notice that the color of the curtain changed in the background? And it was not even subtle. Aha. And so it's going to run it back, rewind it now. Red curtain, the gorilla, orange curtain, the gorilla. So the point that I'm trying to make with this is that though, as a surgeon, you'd be surprised, and this has happened more than once, where I will use some like this to drive the point home is, um, as a physician, don't get focused on one thing because you'll miss a lot of things on your patient around you, such as the gorilla in the room, such as the changing color. They send me to the room to look at the toe, but I have to walk over a puddle of blood, but I know where that blood source is coming from, but I check the pulse and go out and say patient has no pulse. But I just ran over a pile of blood, for example. My favorite thing is that the one this just happened not too long ago. I got called in to go for a bowel obstruction on a patient, and the patient is thrown up, and they have a nasogastric tube, a tube in the nose that's supposed to empty it, but no one had appreciated that that's not even hooked up to the wall suction. So they just put a tube in this patient's nose, patient's thrown up, and no one said, huh, there's a tube in the nose, but it's hooked up to nothing. It's supposed to be hooked up to wall suction. Again, if I'm walking in and I'm focused on this nausea and vomiting and I'm not like assessing the whole thing. So um, uh, moving forward, um, uh, so as I said, I started my education in Glendale College. Um, and went to USC for biomedical engineering, went to American University of the Caribbean, oh my God, and did my residency at St. Joe's Mercy in Michigan. Um, just quickly knowing what I know right now, I probably would have taken the job that I was offered to work for Kaiser, but I wanted to save the world, so I decided to join into a private practice. And I'm a little smarter now than I was 30 years ago. And with that knowledge, I think I should have stayed. I should have taken the offer from Kaiser. And that goes into one of my first slides that I said that the dynamics of the dynamics economy um, uh, and the whole social structure of a health has changed so much that you really have to consider all of these options. Um, it's very interesting because when I sort of look at and I don't know how many of you may even consider going into engineering. You're in biological sciences, chemistry, biology, biochemistry. It's sort of natural sciences it's a discipline and there's some ambiguity built into it just because of the unknown. But when I'm looking at as a biomedical engineer, when I used to design circuit board, it's like the same current, the same resistor and transistor and all that stuff gives the same outcome. Whereas when you're talking about a surgeon, there's a whole bunch of gray zone. You sort of have this barriers or the borders that'll say from A to Z, but no patient fits the mold. So this goes back to, as I said a little earlier, that there has to be a lot of flexibility and tolerance into your long-term plan and short-term plan, both as a medical student and whatever field of medicine you end up going to. For those of you that wonder, to tie a bow tie is like putting your shoelaces on. Just don't make it too tight around your neck. Um, from this point onward, I'm going to go show a whole bunch of pictures for those of you that don't have a strong stomach for blood or you're going to sort of worry about it. You may want to sort of make sure you're sitting down. I'm going to start talking briefly about the uh, obesity. That's what I do a lot of weight loss surgery. I trained in general surgery, did a lot of trauma when I was in Michigan. And then as a part of my residency, we did a lot of weight loss surgery, do all the switches, and that's what I trained. So one of the things I want to start is no matter what field of medicine you all go to, if you need to remember one thing, please remember this from this lecture, nothing else, is that obesity is not a disease of overeating, a lack of exercise. I'm going to say that again. Obesity is not a disease of overeating, a lack of exercise. If you think about it, obesity is defined as body mass index, which is height divided by, your weight divided by your height square. So you can theoretically get more effect by getting taller than losing weight. But no one tells their patient, go jump up and down to grow 4 inches taller, because we know how ridiculous that sounds. And it's as ridiculous telling the patient, go on a diet. For the skeptics who say, well, Lindsay Ossuman and this and that, dating back to 2003, the Science magazine published the relationship between the leptin, the genetic manipulation, and obesity. These two mice, they have one genetic variation that actually coats the melanocin color. And so from the same egg that was divided in one line of the animals, they turned on the gene, the other one turned it off. So these two animals are identical genetically with one exception. And you have a fat white and a thin black gene. So this was the first time in animal that was actually manufactured in a test tube that, yes, we can actually create a model for obesity for testing drugs and this and that. So this is going back in 2003. The all of you that are ready to look at some pictures, This is the heaviest female patients I will operate on, 600 pounds. Just a reference point, looking at the size of her thighs and body habitus. The heaviest male patient that I've operated on is 1,000 pound. And again, just to put a reference, it's sort of hard to tell what's what, but if you look at the size of the wrist on the left lower corner of your image, you'll see that wristband, that's sort of the hand and the wrist. And then you can see where the rest of this is going from there. This gentleman had his operation close to about 20 years ago. He was 21, 22 years old. He's, he's married. He's like 300 and some odd pounds now and living life. Um, uh, Again, just as a physician, as a medical student, when you're a resident, always count to three before you come up with an answer. Never stop learning. I learn more nowadays from every patient by reading and rereading than I did in residency. Um, we also want to treat each other, treat the patients the way we want to be treated. Dr. Malarney years ago in Michigan, where I was doing my training, used to say, listen to the patient. They'll tell you what's wrong with them. You don't need x-rays and labs and CT scan. Most patients will tell you in a fairly accurate detail what's going on. The other pet peeves or highlights, not pet peeves, as you're in pre-med or medical school or eventually going to residency is sit down, look at the patients. There's studies that's been shown that physicians that have actually sat down and spent less time with the patient versus standing in the room were perceived to have been more attentive and spend more time. Just physically sitting down in the patient's room and spending 2 minutes to the patient is worth more than you standing there and talking to them, reaching down, looking top to bottom them. You're looking at them from the top viewpoint, looking down on them, if you would, as less of a time spent. Unfortunately, nowadays we all walk around with an iPad or a computer or a system that you have to type in, make a point of, put that aside, talk to the patient for 1 or 2 minutes, and move on. The other thing that's also very interesting that this comes up, and either at family level or in the practice, is, and this is, I think it's very cultural too, that what are you supposed to do when a patient's family corners you and says, Miyasa mommy, well, I'm sorry, don't tell so and so that they have cancer. We don't want them to know, it's not good for them. That's also not been that's not accurate, it's not ethical. It may actually not even be legal for an adult in the US not to tell them the truth. But it's very interesting how, again, the science has shown that nearly everyone wants to know the honest truth up front. And people that are not comfortable with the truth is themselves, not the patient themselves. So the role of the physician is not just to order x-rays and medication. Be empathetic, be sympathetic, because we will all need this care. And want to talk about health equity. I'm assuming, but for those of us that may not be very clear what the difference between equality, equity, and justice is, and in the scheme of the healthcare system and anything, in social justice, remember health equality is you have three different individuals that you give them the same box. They got the same box to stand on. Health equality is not what boxes you give them, but how do you provide them the same access to the same viewing point or the same level of healthcare. And the other, and justice would be to actually, how do you remove barriers so individuals by themselves without any outside assistance can get to the same end goal. So this cartoon shows, people looking at a field of soccer players, but if you can think about in the care of an access to healthcare, how do we provide the same level of access that everyone can get to the same level of care, regardless of what their ability to pay and what their socioeconomic status is and things like that. So warning for more pictures again. So this is from years ago in Detroit. This young girl fell through some family violence thing through a glass table. Um, uh, Ended up having to put a drain in there because there was a tear of part of the submandibular gland. So what you don't want to do is create a mucus fistula, because if that gland drained and it was not sealed, you'll have sort of a spit fistula. Continuously, the saliva would drain through through the skin. So put a drain in there that's sealed by itself. A few weeks later and a few months later. Um, uh, Trauma surgery is very cool, very exciting for about 2 weeks till you start walking like a zombie after being up day in and day out. So these are some of the series of cases. Some of them are very graphic. So those of you that don't want to see things. So usually a gunshot to the head doesn't do well. This was the emergency room picture that was taken. This is taking this gentleman to the operating room, and that's the suction tip, and that's the bullet that's stuck on the suction tip being come out. That's the bullet, the tip of the bullet on the suction tip being pulled out, and clearly a bullet into the skull, and brain injury doesn't do well. This gentleman ended up having a titanium plate placed in. And just for those of you that may or may not be aware of it, one of the issues with um, penetrating injury of the skull um, that has the worst outcome, not only because of the obvious thing that I can't do without a brain or part of it, is that it's because of its confined space. When you cause any injury to any organ, whether directly because of the bleeding or indirectly because of the secondary swelling, as it swells up, it has nowhere to go. You sort of get the same thing in lower extremities, which is known as a compartment syndrome. And in the brain, it's called increased intracranial pressure. So one of the things was that you can see the injury to the brain here was a relatively small hole, but a big chunk of the skull had to be removed to prevent from pressure of the brain build increase so much to cause herniation. Because if the brain can't expand, the only place that it can go is into the top of the spinal cord, and you get herniation of the brain stem, and that sort of death sentence essentially. More pictures coming up. If I can move these. This is a pregnant lady that showed up in the emergency room, and the father of the child had found something with some other guy in the house, so took a shot and shot this pregnant lady in the belly. The mom had no pulse, and I was a fourth-year resident, I think, and we ended up doing an emergency C-section in our trauma bay in the hospital, in the emergency room, and the baby was dead. This is a right knee bullet injury, two bullets. One of them was thrown through, and the other one was caught into the joint. um, uh, Gun violence is an epidemic of thing. It's at a critical epidemic level in the U.S., and it's been getting worse and worse and worse. Just to put things into perspective, there were more people dying from gunshot injuries in U.S. today than probably entire last 3 months in Afghanistan. Let that sink in. And I think we all, as healthcare providers, need to be aware of this and have a position on that. This is a gentleman that was shot. This was maybe a couple of years ago, and this was actually at Huntington. Got called in to go and crack the chest because There were multiple gunshot wounds to the belly, and we couldn't handle the blood loss. So this is what's known as cracking the chest and clamping the aorta to prevent from any blood going into the abdomen because they can't control the bleeding. So this marker, that's the heart. You can, well, if you've seen a heart before, you'll appreciate that that heart is completely empty. There's been so much bleeding into the belly that there's no blood in the heart. The lung is expanding because the anesthesiologist is pumping air with the machine, and this gentleman didn't do well long term. Well, he didn't do well, long and short term. Uh, sorry, I keep messing this controller here. Another example of a gunshot injury to the belly. We talked about a little abdominal compartment syndrome. This is the gentleman that was shot in the belly. This is a venocavogram where there's a catheter that's inserted from the groin. We inject the dye into the vena cava, and there's the bullet that has penetrated and it's essentially completely occluded the vena cava. For those of you that have not been, by the way, someone is trying to get in. There's a admit some note up there. Um, um, for those of you that have not had just sort of aorta, the vascular system that takes the blood down from the heart, it's sort of it's pliable, it's a good vessel to sew on and things like that. Vena cava, it's sort of wet toilet paper with a little jello on it. So it doesn't really lend itself to suturing and this and that, especially if you have uh, a penetrating injury that has not only cut and pierced it at maybe 1 or 2 or 3 levels, there's a secondary blast injury and even possibly a thermal injury to it. So when you have a vena cava injury, what you do is that you just leave it alone. And these patients end up with significant abdominal compartment syndrome because you have essentially occluded all of the blood vessel, all of the blood flow returning from the lower extremities and about the 2/3 of your GI tract back to the heart. So there's a lot of swelling that builds into it. You can see this patient also had a injury to the right renal vein because you can see the outline of the kidney on the left-hand side and the kidney that's draining into the ureters. There's a catheter, a pigtail into the right kidney, but you can't see anything there. It doesn't light up and it doesn't fill up the ureters. The lateral view shows, so these two x-rays are what we call an AP film, meaning that the patient's belly is at the front, laying on the back of the monitor, and the x-ray is going from the anterior to the posterior. So it's an AP. You can also have a PA. This last image that has numbers written on it is what we call a lateral view. So the patient is still on the table and they put a film on one side, they shoot the x-ray laterally, so I don't know. There's a patient laying down on the table. If you're doing an AP, film goes this way. If you're doing a lateral view, the patient's laying and you shoot the x-ray from one side. The point of this x-ray, you can appreciate that there is these fine blood vessels. Those of you that have already done the anatomy lectures, I won't put you on the spot, but remember believe it or not, there's two parallel systems. There's the vena cava, azygos, and hemiazygos veins. Those are the two venous systems that go to the side of the spine, and they're the accessory system that take the blood back to the heart. So what you essentially do when someone has a vena cava occlusion is about 1 or 2 months of essentially complete bed rest, leg elevation, a lot of blood thinner to allow for these collaterals to develop. And over time, they develop the azygos and hemiazygos veins to take the blood back. In the meantime, what happens when you have a patient that they've occluded their vena cava is you get what's known as abdominal compartment syndrome. There is so much swelling that you can't close the belly. So what we do is we take took an IV bag, inside of it is sterile, you turn it inside out, and you suture that to the entire abdominal wall with the belly open. And every 2 days or so, you take the patient back to the operating room, make a smaller IV bag, and you close it over time. What determines how much how fast you can close is two measures, and depending what you do, one of them you can measure the bladder pressure, so you can put a catheter. These patients all have a catheter in their bladder, so we can measure the urine output, and you can measure the bladder pressure. The other way would be to measure the airway pressure. Clearly, these patients with an open belly are all on the ventilator in the ICU for 1 or 2 or 3 weeks till this resolves. You can measure their airway pressure. I was going to say something, but I forgot. That's what happens when you get old. Pressure. So the key with the increased abdominal pressure is that if you end up with a compartment syndrome of the abdominal pressure, guess what happens? You are able to squeeze the venous drainage back, and you actually can get ischemia of the organs, kidneys, bowel, dead bowel, and that sort of, it goes from bad to worse very quickly, if that makes sense. Again, just continuing with some random set of pictures and things like that. There's the gastroschisis and ophthalmocele. These are two defects. These are more exciting pictures coming up. So these are congenital conditions where children are born with their entire GI tract and sometimes the liver outside their abdominal cavity. A gastroschisis has no sac. You can see there's no sac here, meaning that if you lay me on a table and cut me like a sausage, there's the skin. It's then I have my six-pack abdominal wall, then I have the perineum underneath, and inside there is my guts. If that muscle layer is not there, then the guts can come out. If the guts come out with that saran wrap, that perineal lining, then you have ophthalmocele. That saran wrap protects the bowel from being exposed to the amniotic fluid and the outside world. So essentially, the ophthalmocele, patients that have ophthalmocele do much better from a preservation of the length of the bowel, because the bowel has been protected by the perineal surface and the perineal fluid that's within the abdominal confound. So as far as that bowel is concerned, that bowel, because it's protected by the sac, it's never left the abdominal cavity, which we already know it's not the case. Whereas when you look at the gastroschisis, is missing that sac, and the bowel has a number of problems. Most obvious of it, although it's called mottling. It's sort of stuck to each other, and that's because it's been exposed to amniotic fluid. The way both of them are treated is you have to get them back to function. You have to be able to see how much bowel function there is. These patients have low blood sugar. These babies have very low blood sugar. They have very high risk of developing blood sugar fluctuations. There's also genetic profile issues with some of them. But what you do is that, though, similarly, to avoid creating an abdominal compartment syndrome, you can't just stuff all of the stuff that has lived here inside. They won't be able to breathe. Some of them actually, I think it was the other slide that showed that one of the kids had a chest tube, if I'm not mistaken. Yep, there's a chest tube in this child. This baby also had a deflated right lung, and you can see the umbilical vein that's cannulated. And so what these patients do is that you almost all of them have to have surgery relatively quickly. The idea is that to protect as much bowel as you can. The idea is to avoid having them develop what's known as a short gut syndrome. We can all live without any kidney. We can all try to get liver transplant. You can get a heart transplant, but small bowel transplant has been very difficult and uh, with a relatively low success rate for years. There's a lot of improvement that's been made in the last 10, 15 years I was looking at for this lecture, but there still remains to be a problematic. So in order to not have in order to have the most amount of bowels survive the injury of birth, you need to do something to protect them, provide nutrition to them. So you start feeding the babies while they're still on the ventilator through the mouth, through put a long tube into the small bowel, and you can just start feeding them with some sugar water. The mucosa of the small bowel likes the sugar water. They don't necessarily want, rafi kebab or anything like that. They just need to be supplied nutrition locally. That's one thing. The other thing is that you need to sort of move this bowel into the abdominal cavity, which is similar to that trauma patient. We create an outside protected environment. These silos are made. And over next couple of days, every day you take the patient back and you make that silo, you roll it down a little more every day to push the bowel down into the abdominal cavity by giving time for the abdominal wall to stretch over time. Sometimes we also do counter incision inside of the belly, cut the underlaying of the rectus sheath, posterior rectus sheath, to allow for the muscles to separate so you can get more laxity into the abdominal wall. More graphic pictures coming up. It's not a good idea to buy a lot of fireworks from sort of here and there. Clearly, these two hands are not, they're two different firework accident. Came to Huntington Hospital some time ago, a few years ago. It was July 4th. Yeah, be careful. I think these pictures speaks for themselves. Talking about the sleeve gastrectomy, we talked about a little obesity and do overweight patients have big stomach? Yes or no? I mean, you don't have to answer. The answer is no. Obese patients don't have big stomach. Tall patients have big stomach because those of you that are in the embryology, biology, and all this and that, you appreciate that when the zygote is formed, then the polar ends are formed. One of the first stages that those two polar ends pull away from each other, and you essentially form the bases of the sort of the spinal cord and the base of the aorta and things like that. And the length of the aorta and the blood vessel dictates your base of the root of the mesentery, which also secondarily later on dictates the length of your small bowel, esophagus, and the stomach. So overweight patients don't have big stomach. Overweight patients can't sit down and, more thin patients go to rafi kebab and eat the big plate versus the overweight patients. So this is an example of how the size of the stomach that comes out of a sleeve patient decompressed on the table. And when I hooked it up to the water in the sink and I just filled it up without really blasting, I just filled it up with water till it stopped and then I disconnected it. So you'll appreciate how so this is sort of, I tried to scale my hand when I was doing this slide. I sort of that's my hand holding that. So I sort of made the picture big enough for it to be the size of my thumb. So I said, if that picture was to scale, I know what that length is. So if that's 15 centimeter, what the 15 centimeter would be. So these arrows are supposed to be, if you were to take this as a cartoon of a relative scale, my empty stomach is this. And when I eat food, I can fill it up to this. Now it makes sense when I can go through drive-through in McDonald's. I can have a Big Mac, fries, and a large Coke, and I stuff that in my belly in like 5 minutes. That because my empty stomach is this, when I fill it up is this. Yeah. I want to talk about being a being a scientist and question everything, validate and verify everything you hear. Um, Uh, we can go to any, we can pick up any subject, any position you want, and I'm sure we can find an article that supports your position. It's very important to learn actually how to evaluate a published literature. You want reasonably good quality paper that has a population size big enough with good data analysis to validate your point. I want to emphasize the issue of the empathy, sympathy, and health equality. Um, and patients come to us because they're vulnerable. Um, and uh, as a physician, I can relate to that. When I was having a surgery on my shoulder, it's very interesting how completely um, out of control you are laying in the laying in the recovery room or the pre-op holding area where people are coming and going. And I'm thinking, if I didn't know what they were telling me about, what would I know what they're telling me? So I think we need to look at this from that perspective. Um, how much time do we have?
They're usually like an hour, but you
Okay.
can go
So,
as long as you need.
does anyone have? No, I'm gonna sort of throw a curveball here that sort of confuse everybody. Not confuse, but sort of enlighten everybody. So, can I real quickly understand how many of attendees are in medical school, or how many of them are pre-med, roughly? Yes, you may speak. The hand is for what? Medical school or pre-med?
I don't know, you're asking a question, so I think anyone that's in it should probably raise their hand. So that's one,
Okay,
two,
just
three.
a guesstimation. How many people are in medical school? Does anyone know? Okay, one, two, three. All right. So I'm gonna just show 3 or 4 slides about this whole issue of uh, what is it to go from engineering school to medical school and things like that. Um, I have worked years ago. I started working after being a surgeon. I started working on this condition for strabismus. Um, And this is how you sort of can bridge from different disciplines to medicine. So the idea of this is to sort of, I hope this inspires people to not look at their undergraduate education as a means to the end, but hopefully what you're studying will come to help you down the road, even though in ways that you may not recognize. Those of you that may be aware of the condition of strabismus is when the eyes are not directed in the same direction. And sort of for one reason or other, I sort of a few years ago, I started working on this project of developing a technology that you can not only take a picture and measure the angle of the deviation, but also you developed a pair of glasses where you can tell the glasses where your eyes are located. And when the one eye is deviated, you can occlude the non-deviated eye to bring it in. And real quickly, this is sort of the app has been developed that we locate the position of the eyes. And just as an example, you will see how when this patient sort of deviated eye, this gentleman had sort of a neurologic issue, and his right eye deviates out, eyes, wears his glasses, which is essentially vision therapy, and brings the eyes in, and the app documents the changes. Um, this is another example of how this child had both a vertical and a horizontal component deviation. And the red is the before, and the yellow, these are pictures, 2 separate times, same distances. And when you overlay the images, you can see how it's moved in and a little further inward. So the purpose of this to sort of give you a perspective of whatever you're doing in your undergraduate. Uh, I hope you're doing it because you think there's a value to it, not just a ticket to medical school. And if it is, then good for you. But there's a lot of opportunities out there for things that you may not realize right now that will come to help you down the road. Um, any questions? You don't have to raise your hand. You're the boss.
Sorry. But I had a quick question. So you mentioned earlier on that you not regretted, but you would have rather gone with the Kaiser job rather than go into private practice. So why is that?
So I was warned not to talk too much about politics, but that question has to be politicized. Um, so we unfortunately we live in a relatively ignorant, backward country. And because we don't have nationalized healthcare, um, so that's the fundamental problem, is that when I finished my residency, um, just to give you a context, when I finished my residency, a recruiter sent me to Kaiser of Vallejo, and I was at also South San Francisco interviewed me, and Kaiser of Vallejo interviewed me, and I was the seven or eight surgeon in the group, and I'm thinking, okay, if I get hired here, I'm gonna spend the next 20 years taking care of hemorrhoids and ingrown toenails because that's gonna be the crappy cases you get as a new surgeon because the other ones are gonna take the cool surgeons Monday through Friday, and I just don't want to do that. For one reason or another, I then another recruiter had said, there's a job in Delano. I'm thinking, where the hell is Delano? There's nothing in the middle of nowhere. When I went there, these two surgeons said, they're retiring, so you can move in, and then within a couple of years, this practice will be yours, which ended up being sooner than that. A couple of years later, one of my senior partners died, the other one retired. So in a matter of 5 years, I went from being the new kid on the block to having 4 or 5 surgeons in the practice. So on the surface, it looked really good. But as that was going on, the health insurances were cutting down reimbursement, complicating the paperwork. So now I'm going to share you all of these slides are worthless unless we talk about the business end of it. You've gone through that. You've gone through years of undergrad and medical school. You have your student debts, and you've essentially, as a surgeon, you've sort of been out of commission for about 13, 14 years. So there's 13, 14 years of uh, energy that you spend, and you're trying to reap the benefit of that, both financially, emotionally, reward of being a professional and all that stuff. And in a matter of literally 10 years, it went from uh, being able to not to at all worry about which cases you're doing and who's paying for it and this and that to like, okay, well, we did so many cases and our reimbursement is 30% of it now, where before it was not the issue. Whereas if you're working for Kaiser, your overhead, your income, your expenses are all irrelevant. You do what you're trained to do. I show up there to take care of the patient. I don't care what insurance they have. I don't care if their deductible is being paid. I don't need to worry about if my op report is signed correctly so the Blue Cross will not reject it because I signed it with a purple pen versus a red pen. Is it typed or is it handwritten? I mean, there's a whole bunch of stuff that you may not appreciate that. Look at this point in your career, looking at that information, yes, I wish that would have been a much wiser decision for me to do. It would be foolish for anyone to think that you can go into medical school and get out and open your private practice today. Unless your dad has a trust account of 5 million and says, go spend it. Yes, you can maintain your practice for $5 million on a trust account while every month you're losing money. It is physically, it is financially impossible to do that, especially in big metropolitan areas. Now, if you go to smaller towns, smaller places that your expenses are much lower, your costs are much lower, but there's some fixed costs you cannot address, then there may be more doable because you will be able to probably do more cases, more opportunities to do different things. I mean, the other way to look at it is that, um, 20 years ago, you never thought your dentist will try to do the Botox on your forehead. How is a dentist do Botox injection? Why is a GYN doing I don't know, liposuction of inner thighs. Just because they're in that geography doesn't mean that they're an expert in it. Because everyone is now doing the liposuction and Botox and what are the laser treatments. Because if you are in an environment where you're not stabilized, you're not established, and you don't have a clientele coming and going, you have to find a source of revenue. I don't know if that makes sense or not. That's not supposed to discourage you, by the way. Don't give up and quit your day job and quit medical school and go there. I'm just saying that we just need to have realistic expectation, because I think there's a lot of sort of this you may be presented with facts that have a lot of bows and arrows and the flowers and this and that fluffy on it, but it's I think it's important that we know what we're getting ourselves into.
Thank you very much.
You're welcome. One other thing I will say is that, and Sophia can go next. By the way, I would not change anything other than going to Kaiser if I could do this again. I couldn't do anything else other than being a surgeon. I would have still gone to same school, same thing, because it got me where I wanted to. It just, that's the reality of learning from your life mistakes, and you try to pass it on to others. Sophia.
I have a question. What made you decide to go into surgery?
Well, I don't know. How do I say this without sounding like an ass? Uh, um, I think I've shown you my the yearbook that we made, right? In that, I didn't say I want to become a doctor. I said I want to be a surgeon. I can't see myself doing anything else. I'll probably jump out the window if I was talking to the same patient for blood sugar or blood pressure. If I was a radiologist, I'll probably hang myself in a room. You just have to do what you like. And I mean, an ignorant surgeon's position, if I was a psychiatrist or a psychologist, would be just snap out of it, honey. We all have bad days, I mean, and I'm saying this with tongues and cheek of just trying to be humorous. And when I said we have to be empathetic and sympathetic, but I think it's important to know what works for you. I would probably say I know a lot of physicians who are extremely unhappy with what they do on a day-to-day basis. I love what I do. I can't wait till I go to the operating room tomorrow and cut on someone. In lieu of all of the complaining that I did to all of you about the business aspect of it, I can't wait till I go and cut tomorrow morning. And I know a lot of colleagues who are miserable in what they do. And you don't want to get into that point, because unless you really love what you're doing, all of the other items on that list that may have look attractive are not there. No one's going to bring a lot of money to you with a wheelbarrow anymore. No one is going to just, roll the red carpet for you because you're a doctor. No one cares. No one should care. But I mean, it's even more pronounced right now. So unless you really love what you're doing, it's going to be a very bad investment in your life and future if you don't know what you're doing. What do I like about being a surgeon? I think it's very intense. Most surgeons, I think, need to see therapists. We all have issues. Some of us should actually be medicated. But we are, to some degree, drive on the high of being able to do a bunch of things at the moment. And the best part of it is that, it's there. You cut and sew, patient's better or not better. You don't give someone a set of, and I don't mean to talk down to anyone who wants to go into medicine. Please do, because you're needed in the field of medicine. Someone needs to do this. But the idea that I want to see the same patient today and give them cholesterol medication and have them come back 6 months for me to say, yes, your cholesterol went from 220 to 210, that's a success, is just, let me just cut something off and I'll know in 10 minutes if it's working or not. Again, personal choices.
I have one more question,
Mhm.
unless
Yes.
someone else has a question. I was recently talking to a psychiatrist and kind of saying what you're saying.
I didn't know you were seeing someone.
No, I'm not.
Oh,
He was mentioning how he actually has met many general surgeons that have left their practice to go pursue like another residency into psychiatry. And I guess from your experience of like,
I told you, some of us need to be medicated.
no, I
I have
understand.
seen surgeons that have issues. And I'm not joking. I mean, there are people that have issues.
Yeah, I know that, but like what in their field, like being a general surgeon, from your experience working with these people that are miserable, like what causes that to make somebody to want to stop what they're doing and go pursue a completely different field?
Um, well, I'm sure everyone has a perception of what a surgeon is or what a surgeon does. But let me give you what a surgeon does or is from a surgeon's perspective. Um, we're very uptight and we are perfectionist, wanting to do it in our way, one way, every time. And if you're not doing it that way and someone says something, immediately the thought process that, oh, what an ass. And the reason for that is part of it is that is what we do matters, and what we do in the operating room is dependent what everyone else in the room does it the same way. I am in the operating room, I'm operating on someone, my head is into that wound, and I take my hand in there, and everyone knows that I'm left-handed, and I've got a blood vessel that's bleeding, and I bring to suture that in, and the needle is in the wrong direction. That really is irritating. And to a third party may think, well, what's the big deal? Turn the needle around. By the way, for those of you that have not been to the operating room, imagine if someone gives you the fork with the pointer into your palm and say, have a steak. Well, it jabs you, for example, and you're not paying attention. You can't pay attention because your eye is in the field. So there is that perfectionist sense that you have to be right every single of the time. I can't just sort of give you an antibiotic for the UTI and say, go back and come back. Well, if it didn't work, I'll try something else. I have to make sure I'm right that time, every time. So that's one aspect of it. When you, in the cases when there will be a complication, everyone steps back and points the finger at the surgeon because as a captain of the ship, everything comes to you. So you have to have a thick skin to be able to deal with that. I think we need to, as a surgeon, you have to learn from every mistake. I've had a complication today. I need to do the same case tomorrow to learn from that so I don't get gun shy from doing the cases. What I've seen is people that actually got into surgery and got burned out and they really shouldn't have been there to begin with is people that were not prepared. Their expectation of this romantic life of a surgeon that you walk in and put my hands up and someone gowns and gloves me and I walk in and everyone praises you and this and that. It's not that. You need to do the work. And so the the sort of layers of that is that a non-surgeon can multiply their work. So a primary care can hire 5 nurse practitioners, put them in the room, and have everyone write an antibiotic, and you still expand your business. As a surgeon, I can't do that. I can only take one appendix at a time. So that translates into more workload and more burnout rate if you don't pay attention. And um, unlike a lot of other professional surgeons that actually quit and stop, they die relatively quickly because we're sort of hooked on being junkies on the high of being in the operating room. That's the reality. You know, that's why you'll see people that find something else to do with their professional life. If not, you become obsolete. And it's this is not just being a surgeon, it requires not only the high level of mental acuity to be sharp on your skills and this and that, that also needs to translate into your dexterity, being sharp with your hands in the operating room. And, when I was training in residency, we did a lot of open cases and some laparoscopy. And then 10, 15 years ago, I had to learn how to do robotics. So, there's always this newer technology that you have to learn and to be up with it, and compared to that to other fields of non-surgical fields of medicine, it's like, yes, I have to learn 5 extra antibiotic that have come up last year. And, I've got a patient right now in the hospital that I was talking to the ID guy, gave me two names. I know what they were. I had to look it up, and they're new antibiotics. I never heard of it before. So I don't know if that answered your question or not.
It did. Thank you.
Just have fun with what you're doing. It's a lot of fun. Love what you're doing, and it'll work great. And Arpine, you're happy?
I'm stressed, but I'm very happy.
There is no reason to be stressed.
The stress doesn't go away, but I mean, it's worth, if you like what you do, it's worth it.
Yes. Any other questions?
Doctor,
Yes.
so you say you love surgery. That's great, but um, how did you figure out that you love surgery from a young age? How did you decide you wanted to go into that? Because me especially struggled with that going into college.
I I'm sorry, you said something about a college?
Yeah. So um, going into college, personally, I struggled with um, figure out what I loved and what I wanted to do. How did you figure out you love surgery?
Um, well, so you sort of have to have a self-reflection of what is that you like and what you don't like. So, I'll take your question one step further back, and I'll say, why do you even go to biomedical engineering? That's because very early on it became evident that I don't like biology. I hate biology. I think I also don't like biochemistry. I don't like chemistry either. So, it's sort of an ironic that I ended up in medical school and I'm a surgeon. So the bridge for me was that, okay, I'm going to do biomedical engineering. I think it gives me enough tools to get into theoretically a medical school in the Caribbean as maybe, but it got into where I wanted to. But also I was looking at this, if I cannot get to a medical school for whatever reason, what the hell am I going to do with a biology degree? I don't know what the exit strategy would be. I didn't want to get cornered into that. So that was one. And even if you look at that decision, it was based on that I just am a very I like being technical with my hands and not just sit in a cubicle and sort of think about what antibiotic to give. And I'm not dishing anyone else. I'm just, I'm being honest and transparent what I know, what my limitations and my deficiencies are, and what my assets are where I can capitalize on. I like working with my hands. I like doing things. I like being active. I like to be on a go. I couldn't see myself sitting in a room. Even if I ended up being in engineering, I could never see myself sitting behind two monitors and design a circuit board. I would be the one that would actually be physically making it and try to make it work. So I think you need to sort of look at your own personal likes and dislikes. And I don't necessarily think this has to do, whether I'm studious or not. I'm not very studious, but it's about what works for you, what doesn't work for you. Are you more of an analytical think that you will sit down and sort of think about these uh, uh, pathways and biochemistry of this and that, and versus would you rather do things with your hands? And to take the other extreme of this, for example, I couldn't see myself being an orthopedic surgeon, because to me orthopedic surgeon becomes way too monotonous and that pendulum of being in medicine and being helping something is the other end of the spectrum, but you're essentially doing very little patient care. Everything is done into, I'm just going to cut the bone, put another one on, and dish this out to physical therapy and let them worry about it. You know, again, that's a personal choice.
Got it. Thank you so much.
You're welcome. Do you know what you want to do?
Yeah, I'm a third year now, so I figured out I'm pre-dental. Um, it took a long time of just self-reflection, like you were saying, but eventually I figured it out. So,
Very good. All right. There's nothing else. Thank you.
I was gonna ask a question real quick before you headed out. Sorry.
Sure. No.
Yeah. Pretty much. I was kind of also considering looking into like, because I'm pre-med, but considering looking into those med schools in the Caribbean. Would you recommend the one you went to? Like, did you like it, and was it like easy getting into it? I know it's been a while since you had to think about that, but um,
Um, so I went to the Caribbean school in 94. I don't think you were born. I don't think anyone in this room was born. So
yeah,
having
yeah.
said this, no, I want to preface my answer by saying the following is that number one, we are in this 30 years or so, I've had maybe two or three patients that have ever asked me, where did you go to medical school? And I give them the answer. And in fact, those are the patients you never want to see them in your office because if to them your medical school is a determining factor, those are the people that are going to keep knocking on your door every day with their incision being red, blue, it's big, small, and this and that. So, with that having said, I have, I know a lot of people that have gone to Caribbean school for one reason or another. Uh, the issue ends up being is that though there's an equalizing factor at the end. Oh, I didn't actually realize. Hold on. There's an equalizing factor at the end, and that's called your board. The USMLEs and the board certification and things like that. So I've taken the same board that anyone that went to Johns Hopkins took it, and I just took my third recertification about 2 months ago, but no, about 2 weeks ago. Uh, so I don't know. I don't know what the entrance criteria is. Um, the reality, I think, going to a medical school like Caribbean would be that if you want to one day be a dean of a medical school, or if you want to aim for working for NIH, well, if anything is left of it, unless they tear it down, then you have to go to a school, a prestigious school that has a name recognition for just that name recognition. Um, uh, my experience in the Caribbean was that though we showed up there, the instructor or the professors that were there were one reason or another all from U.S. schools. They were there on a sabbatical, holidays. We had actually two people that their spouses were in the medical school, so they took a year off, come down, teach the classes while their spouses were in the school. So, but having said that, my experience was that someone would show up in a class, they'll give you the lecture, and you're essentially responsible for the whole thing. And it was the same books that they all use in medical school anywhere else. And when I was going through, you had to pass and some of other people may have more information on that too. You had to pass the USMLE Part 1 to be able to do your rotations in the US and take the Parts 2. And then I got my residency in Michigan, did 5 years of surgery there, and here I am. Anything else? I don't know if that answered your question or not, but yeah.
For the most part. Um,
What part did I miss?
oh no, you could no. I mean, like, it just like brought up some questions for me that I need to answer myself, but for the most part, it did. Um,
Can I share some
Yeah, I can't
advice on
remember.
that? Because when I
Yeah.
was applying to medical school, I did look into the Caribbean schools, and the application process is a lot easier than um other medical schools. Like
Mhm.
you just submit like their application on their website, and then someone's gonna like call you the next day or 2 days later. They're gonna ask to do an over the phone interview with you, and then they'll give you like two start dates on when you want to start. And at the end of the day, kind of like how Dr. Keshishian was saying, you do finish with your MD degree or DO degree based off of which school you go to. It's the application process is way easier than what you have to deal with going to like a school in the US. The only downside is you probably want to do some research on like statistics of matching into a residency based off of the specialty you want. So if you want to do something more competitive like plastic surgery or orthopedic surgery, Caribbean may or may not be the best bet, but that's things that like you need to do research on your own to kind of figure out based off of the specialty. Does that answer your question?
Yeah, that was like the main thing that was on my mind, the residency part, 'cause I heard that it was that's like the main like reason why it's kind of just like people don't opt for that route because it's like it's harder to match into residency after going into schools there for some reason. But
Yeah, and to learn more on that, like I would still look into it and then maybe even ask the school for statistics because those are things that the schools have and they can offer you and they can kind of break down what their residency matches are and like particular reasons maybe why their students are not matching.
mm,
So those are things I would look into based off of specific schools.
for
I
sure.
think I'll correct that by the following thing. Number one is that though is I would not ask the school. Um,
Mm.
I wonder if there's Sophia, did you check? We are talking about this some time ago. Isn't there like that green book published by AMA for residency programs? Does anyone know? There's a book. There used to be a publication called the AMA Green Book.
AMA Green Book, yeah, but this is like from like 19 something through
Yeah,
2000
that's.
to
I went to
2001.
school when there were dinosaurs still around. That's what I'm saying.
Yeah, no, I don't know if they still use
No, no,
this.
no. It's ACGME Graduate Medical Book. No.
Oh,
But anyway, so I a better source would be to there has to be a database that gives the matching information to find out what percentage of the people that match into residencies were from which schools and ECFMG versus not. When I applied to AUC, they had very strict criteria. One of them is that you could walk and talk at the same time to complete the one-page application, and you could pay the tuition. That was it. AUC lets anyone in that has a pulse, but you have to pass the boards to graduate. That's difference. If you ignore everything else, if you put everything aside, the US medical school do all of their screening ahead of time to put you through ringers to see who gets in. AUC said, as long as you can write the check, come on in. If you have a pulse and you can walk to the school, bring your checkbook and come on in. Get a loan and come on in. They don't care. But you will not get out. And so that's why, for example, at least in our class, there was a very high failure rate. There are people that, I don't think they should have gone into even a community college, much less medical school. They lacked common sense, they lacked discipline, they lacked everything except they have the money to pay the tuition. So they got in, but they never finished it. So it would be interesting to actually see if there's information out there um, that talks about matching. There has to be a book.
I don't know if there's a book, but if you like look on their website, like AUC, for example, it breaks down how many residency placements they've had, um, and what specialties and what states and territories. It's from my experience, it's usually the school's the one that like posts their statistics, but I don't know if there's a book you can look into. All right, does that help?
Yeah, definitely.
Okay.
Appreciate you guys.
Mhm.
And as Sophia said, if you want to go into some very competitive field that historically has been competitive, you have to strategize on that. Having said that, I think it'll be also important to appreciate that trying to, at this early in game, which is you're in second or third year in pre-med, you're looking at 1 or 2 years to complete this, then 4 years of medical school. Then if you want to go into a surgical field, you have to do 1 or 2 years of general surgery, then match this. You're trying to predict what's going to happen 10 years from now. Can you look back 10 years ago and predict where you would be here today? Or our politics would be here today? Sorry, trying to not to mix politics, but it's hard. So what I'm trying to say is that if I may suggest, do what it needs, what will get you to the end result, by not trying to play a poker with, if I do this and I don't get this, then what do I do? Have an alternative plan. I think trying to delay getting to medical school for 2 or 3 years just because you are afraid that you may not get into a residency program may not be the wisest professional, educational, or the financial decision, because that's the reality. Every year we get older, it's harder to. I forgot what I was saying, for example.
I've heard that a lot, that like I've had a lot of relatives that like when they would try to like go back to school and they like didn't prioritize it in their early 20s, it just became really hard.
Yes, it is. And the part of the variable that I was trying to say, and I don't know if it impressed on you or not, is you're trying to predict what the market for plastic surgery, for example, is going to do 10 years from now. In my 30 years in surgical, when I was going to surgical when I was in Detroit, my fourth year doing medical school, that's when this primary care push was coming out. You could not get into a family practice or internal medicine residency because everyone was flocking to it. Everyone wanted to do that. And then within 3 or 4 years, you could get into a surgical residency program because everyone that had saturated, everyone moved into that field. So this has been always a rotating thing. And plastic surgery may be very competitive, but there's a lot of starving plastic surgeons. There's a lot of plastic surgeons. If you think about who's doing everyone's Botox, there may be the same 20 people whose name goes around in Glendale. There's hundreds of plastic surgeons that are barely doing anything. I mean, that's the reality of it.
Yeah, I agree. That career is kind of just unethical in my eyes.
Well, which is why, what we talked about earlier, do what you really love.
Hmm.
On one of the earlier slides, as I said, mark your target, keep your eye on the ball, and you'll get there. This may take a left and a right turn, you may be up and down, but keep your eye on the ball, you'll get there. It's bad idea trying to second guess, to change the target based on what's happening to you at every given time.
Sure.
You have to be flexible, but keep your eye on the ball.
I agree. Thank you.
You're welcome.
All right. So if there are no more questions, thank you very much, everybody, for coming. And thank you again, Dr. Keshishian, for joining us today.
You're
We
very
really
welcome.
appreciate all of the insight you provided.
Very good. Nice seeing you all. Have a good day. Thanks.
Thank you, guys.
Thank
Good night.
you.
Good night.
Good night.